All right, so if we can convene. I see that the screen is asking for a sign-in. Whoever is looking after the screen, that probably needs to go away. Good morning, everybody. Thank you all for coming. Thank you for joining us. For those of you who I don't know, I'm Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. And welcome to this symposium, which is part of our series of Dean Symposia. Just to frame this, we do a symposium where we convene roughly quarterly. And in these symposia, we're tackling issues that are of real consequence for the health of populations and that are, we feel, are important issues in our time. And what we have been doing is we have been convening experts from outside the university combined with experts within the university to really try to grapple in depth with a topic. And what we have found is that these are interesting, dynamic, vibrant conversations that help move our thinking and our collective engagement with the topic forward. And I expect that today's topic will be very much the same. Before I frame today's topic, I want to start, as I always do with these symposia, to acknowledge a few people, because we gather outstanding people for these symposia, and frequently a lot of work that goes behind them is invisible. So first of all, I will acknowledge that this symposium, as you'll hear in a second, is the brainchild of Professor Sally Bachman, who is been working on planning this for about a year. And you'll hear from Sally in a second. And the ideas that have inspired this symposium very much emerge from Professor Bachman's work. This symposium is sponsored in part by the Charles Donahue Frontiers in Public Health Speaker Series. And Charlie Donahue, where's Charlie? I know he's here. He's right there. Is a member of our Dean's Advisory Board, and we are able to create events like this in no small part thanks to the generosity of our partners who are very much both thought partners as well as make it possible for us materially to be able to host people like this. So thank you, Charlie, and thank you to our entire board. Behind the symposium, there are two teams of people working at the School of Public Health. We have a Dean's Office team that's led by Katherine and a communications team led by Cara Peterson, who are partners in making these things happen. And in particular, I want to acknowledge Meg Keating, who is walking around somewhere, who is the glue that makes these events happen. So thank you, Meg, and thank you, Cara and Katherine, for your work on that. So those are the acknowledgements. Now, let me just say two things about the topic itself. So this topic, we're doing this now, I guess it's probably our fifth or sixth symposium that we've done, but in many respects, it's very much core and foundational to everything we care about at the School of Public Health. Our mission at the School of Public Health is the promotion of the health of populations locally, nationally, and globally, and the narrowing of health gaps and making sure that there are no health have-nots and health left behinds. And when we're thinking about doing a symposium on this, we chose this title, Reducing Health Inequities, Advancing Meaningful Change. And there are two important parts of the title as far as I'm concerned. One of them is that the word inequity is in the title. And this reflects, I think, a move forward in our thinking, that we're not simply talking about measured inequalities. We're actually talking about inequities which reflect a mismatch between health outcomes, health indicators in different groups with underlying systems and structures of injustice that ultimately shape these inequities. You're going to be hearing a lot about that today. The second part of the title is Advancing Meaningful Change, that we wanted to make sure that the symposium, while surfacing the issues and engaging us all in thinking about these issues, actually helps us think about a step forward. As you are going to hear many times, the challenge with these inequities is that they're persistent. As you're also going to hear, we've made progress. We've had some narrowing of inequities, but they have been persistent for decades and decades despite extraordinary effort. So one of the core questions is, given all that, how do we move forward? And we have challenged the speakers to address both of that, both to help us frame this question of health inequities and to help us frame how it is that we can move forward. What are key points of influence? What are key levers that we have to actually to advance meaningful change? And in no small part, we see that as part of our responsibility as a university, both bringing together convening thoughts so that we can think about the problem, but also guiding and leading the way to teaching that to our students and to figuring out what can be done to improve these conditions. And that's what we are here to do today. So thank you all. Thank you to our speakers for coming, many of them from far away. Thank you all for joining us today. And now, before I step off, I want to make comment that this symposium is co-sponsored by our colleagues at the Dean of, by our colleagues at the School of Social Work. Professor Bachman has a joint appointment between Social Work and School of Public Health. So this was a very natural symposium for us to co-host with our colleagues at School of Social Work. And Dean Gail Steckity is going to make a few remarks and introduce Professor Bachman. Thank you all for joining us. I look forward to the conversation today. Gail.
I want to thank Sandro Galea and his terrific team at the School of Public Health for sponsoring this, and I'm delighted to see a pretty full audience, and it looks like we may in fact need more chairs, which would be a wonderful experience. Those of us in Schools of Social Work, there are several among your speakers today. We are administrators and faculty at different schools, including the University of Michigan, the University of New York at Albany, how does that go, Darrell? And Tom Byrne from our own BU, and David Takeuchi from Boston College. So social workers are well represented among you, and I know some of you in the audience are also. I know one of the things that we like best is these kinds of interdisciplinary conversations. They are fabulous experiences for us in helping us move issues forward like this. I want to introduce Professor Sally Bachman, who is also directing our Center for Innovation in Social Work and Health. And in those roles, Sally and I have many conversations about where the center is going next, what we need to do as a School of Social Work, and how to work particularly on health inequities, which is a specialty of Sally. You'll find all of the speakers' bios in your program. Sally's in particular. She's done terrific work on children with disabilities and the financing aspects of health inequity and health care. So it's my pleasure to introduce your MC for the day, Professor Sally Bachman.
Good morning. Can you hear me? Wow, we made it to this day, 1 year in the making, and look what happened. You all came together. I'm absolutely thrilled to be here. I'm absolutely thrilled to look out and see all of you joining us today for this stimulating conversation. In addition to all the thank yous, Dean Galea, Dean Steckity, Charlie Donahue, the folks at the School of Public Health who've helped to organize this, Katherine Ettman, Meg Keating, Kara Peterson. I also want to have a call out to my colleague, Maddie Walkman, who works with me at the Center for Innovation in Social Work and Health, MSW MPH student Jessica Margolis, who helped me quite a bit in the planning of this, Rebecca Grossfield from the School of Social Work, and my staff at the Center for Advancing Health Policy and Practice, another group that I direct. Like many academics, I have different hats that I wear at different times. I want to really begin by expressing gratitude. I find I don't have adequate words to express how much I appreciate the time that our speakers are putting in for our benefit today. For all of us to have access to your brains for a day is truly a gift. And I've run out of words to say how much I appreciate it. But I hope you can feel how heartfelt it is, and that I appreciate you being here to help us with this conversation. So I'm not going to read the bio of our first keynote speaker, Alfredo Morabia, who has come here from New York. He has 2 titles, Professor of Epidemiology at Queens College and SUNY, the SUNY University of New York, and Professor of Clinical Epidemiology at Columbia School of Public Health. So I decided to do a little digging. I didn't find anything untoward, but I did find out that you speak 8 languages, including Ancient Greek, which I thought was incredibly impressive, and you're also a master swimmer. Truly a man with many talents and skills. I would like to give a personal thank you to Dr. Morabia, who is helping us put together a supplement for the AJPH on social work and public health. And your guidance and thought-provoking conversations have been truly helpful, so thank you for that. So the rest of Dr. Morabia's impressive accomplishments are in his bio. 8 books on epidemiology, literally hundreds of peer-reviewed manuscripts. It's quite impressive. So thank you for being with us today, and it's all yours.
So good morning, everybody. I'm really, happy to be here. And, when the invitations are made by Sally and by Sandro, it's extremely comfortable, friendly, and it's just, I'm just very happy to be here. And I want to say that when I was first invited a year ago, I kind of resisted coming here, because Sandro knows and Sally knows that I don't write about social inequalities. I have no publication on that. I don't publish on that. And so they want me to talk about defining health inequities, where there are many more scholars, academics, experts that could speak much better than I can on these issues. So I suspect they did this because they want to educate me. and Sandro said, well, I'm going to give him his task, for a year he's going to work on that. It's not going to be lost. And he's probably right. And my first reaction said, well, what could I say? And said, maybe it could be a chance for me, it was a year ago, to test an aspect of a new textbook on the history of epidemiology that I have prepared and with other historians, and which is built as 2 volumes. I mean, one is a slim narrative of the history, goes from, the beginning of history until today, and 6,000 years. And the other is a very large volume filled with key passages from original documents, primary documents. And there's a lot of keywords. And the idea is, since I see that besides very few people, like me, who actually teach history of epidemiology as a full course, very few people do that. They actually add to their course some elements of history. And I thought, someone who would do a course and wanted to talk about the history of how to define health inequities, they would take the volume and look at the key words and look into the key passages and actually build their own, history class. And let's see if this works. And I've tried to do that. And I came out with a lecture, but what would you have said? You would have said, well, that's nice history. That's the usual thing. History is nice. If I had more time, I would read more about the past. And it's a great hobby. He's very lucky, to have all the time to do that. But history is not that. History is what we're doing now. The only real palpable history is what we're doing. The past doesn't exist anymore. It's an abstraction. We can rebuild it because it has left some traces, but it doesn't exist. What's really history is what we're doing now. And we tend to forget it. And I said, I want to, to stress how important history is when you want to define inequities. And when you define inequities, it's always in a given historical context. And I thought, today, I can maybe convince you that history is important better than I could have done it a year ago. Because all of us here, we are suffocating of anger, of shame, when we see a powerful government inflicting violence to some of the weakest people on earth. I mean, some of the people who are most in need on earth, refugees, people that have lost their community, have no one to protect them, often have lost their friends, their family, their children, have lost their way of life, their culture, have no government to protect them. They are seeking, a hosting place where they could, integrate themselves, help become useful again. And what are they getting? Huge violence. And at this moment, you feel history. You know that what we're doing is in a context. Everything that Eliseo was mentioning yesterday night, all the progress we've been doing in public health. And it's been getting better. There are still inequities, but globally, for all the sectors of the population over the last, let's say, 30 years, improvements have taken place. But because history was cruising, we didn't have to think about it. But now it's back, and it's biting our neck. And it's not sure that those things are going to continue because the historical context is different. And so in this situation, I just want to take a minute to listen to our great American philosophers.
And there's another enemy. And that enemy is the immigrant. And you see, it's interesting. It's not just a question of preventing people from other countries from coming to the U.S. and trying to establish a life here. It's a question of presenting certain kinds of people. People from certain countries. People from third world countries. People from Central America. People from Asia.
So when the immigrant is the enemy, this is a very bad harbinger. And this means that history is back with us. And this is the context in which I would like to tell you about, definitions of health inequities and the importance of history, because the context in which we actually define those inequities matters. And today, clearly, we are in a different historical context. Everything that we're doing, maybe have different impact than what we were doing yesterday. And so I hope that you will feel that my message is not just, kind of interesting cultural discussion about the past, but something that is highly relevant to the present. So first of all, when do we start defining inequities? For most of human history, since they are a written document, let's say 6,000 years, there is no definition of inequity because we're lacking the fundamental concept that allows us to define inequities, and this is population. For most of human history, the differences between people who are privileged or not are explained by individual factors. It's in their blood, it's in their heritage. It makes sense to think that the leaders in the antiquity thought they were of divine origin, because this was the only type of explanation. It's only in the 17th century, and when I'm talking 17th century, it's the time when the Pilgrims come here. It's a time when Europe looks like in the Three Musketeers. It's in this century, which has been the most violent, bloody, murderous century of European history, just coming close second to the 20th century, that a huge scientific revolution took place, a huge intellectual revolution took place, and people started to build knowledge from what they could observe and from observations, not from speculation. And it's in this context that in 1662, which is, to give you a reference, 2 years before New Amsterdam became New York. You know. So in 1662, John Grant, whom I have, do you see him? I mean, it's maybe him, it's not sure, but that's because unfortunately all of his estate burned down in the fire of 1665. We have no trace, but this is, his serious historians think that this is a portrait of John Grant. And I like it because he's young, the age he must have been when he wrote the observations, and it was quite unconventional, you know, leaving his hair, you know, flowing on his shoulders. And he actually worked on 3,500 sheets of data that were called the bills of mortality and were the first death certificates. And I imagine him, you know, working on, you know, and just he must have attached his hair in the back, and he had his ink and his feather, and he worked on 3,500 pieces of, you know, parchment, and he got this, which is actually the original table, you know, and it's also the first table we've ever known that has number in them. And when he looked at these numbers, and I can't go in detail, but he discovered something that no one had, you know, imagined before, because you could only discover it in data, that there is something in populations which is very unique. Populations are predictable. You can predict the number of deaths from tuberculosis from year to year. How can you do that? Because populations are different than individuals, and you can compare them. And once you have this tool, you can start defining inequities, because you can compare subgroups of the population who are more or less privileged. And the first description of a difference of this type is in the observation in his book, and he compares the rural part from the countryside from the city of London. And he says that, sorry, the country is more healthful than the city. That is to say, although men die more regularly, you know, there are not those peaks of epidemical deaths, there die fewer per rata. So as the fumes, steams, and stenches, which is what we would call here air pollution, although they make the air of London more equal, so we're all exposed to the same type of air pollution, it's not more helpful. So this is a comparison, and you need this type of comparison in order to define inequities. And so from this point in time, we had at least the conceptual tool. And we have to wait. And this is what's common to all of us, whatever our definition is, that definition, you know, inequalities are characteristics of population, not of individual. You can't say anything by comparing two persons, even twins, but you can derive inferences and knowledge by comparing groups and population. So we have to go now to the 19th century to have what I think is the first, but still the most common definition of inequities. And it was based on a development of those bills of mortality, which became death certificates. And with these death certificates, people collected information about the people who had died, you know, like their occupation, etc. And so it became possible to look at differences of health outcomes across categories of population who were more or less privileged. And the people then, and it's more or less at that time period, I just saw that this university was created in 1830 something, 34, 40, I don't remember exactly, but it's more or less that period of time, 1830s, 1840s. You can imagine Oliver Twist, environment, gangs of New York. I mean, that's the type of environment. Well, social reformer used data to show that, some parts of the population were suffering more than others. And it gave, way to this type of categorical definition of inequities. And this is from the Black Report. It's from the 1980s. And you don't need to know the detail of what you're seeing, because it's all about, the categories of social class based on occupation. But you see the trend, they're all in the same direction. And I put those two pages together and these other together. They all are, monotonous trends that shows that, people that have a higher social class die less than those of a lower social class. Of anything you say, you can choose cancer, perinatal mortality, and it all goes in the same direction. And so I think this definition is still the most common, but it has a huge limitation because of it's simple, but it's also very simplistic, because it means that you actually have to identify those sectors of the population who are more at risk, the poor, and intervene among the poor. And the rest of the society is not necessarily involved in this process. And it works. It works very well, because actually the slums, the poverty, was eliminated by these types of intervention based on this type of data. Building sewages, improving houses, improving nutrition, all this improved the life of people, even though it was based on a completely wrong causal explanation. People who believed in this type of data thought that, the cause of tuberculosis, of typhoid, or any other type of cause of death that was mostly infectious, that was caused by air pollution, by some, pollution emanating from filth. So the theory was completely wrong. But still, it meant that cleaning slums, improving them would have an impact, because it would eliminate this type of miasma. And actually it did. But I think it's still the way people think of inequalities, identifying the poor, identifying the least privileged, and helping, trying to improve. It has been like that in my view, and again, I'm a very superficial observer of these things. I don't have a very deep scholarship on those issues, but I see a change in the 1980s. In the 1980s, there is some very generous theories that emerge, and I think they reflect what our society had become. After a large phase of expansion, very liberalization on many domains of our social life, the effect of the 60s, 70s, very generous theories saying, they are not the poor and us. We're all together, We're all responsible for all. And one of the main theoricists of these new theories, which is a different way of defining inequities, was Geoffrey Rose, an English epidemiologist from the London School of Hygiene and Tropical Medicine. And he did two observations which were really crucial. The first one he said, look, this is this monotonous, trend that you see across levels of risk factor. This is cholesterol and mortality from heart disease. And so you have this trend here. But actually, it's not sufficient to identify the people that actually suffer most from this exposure. Because the people at higher risk, these are the prevalence of cholesterol in their population, and this is the number of deaths you can expect from these groups. They are not so numerous. And so they are at high risk, but they are not so numerous. Where all the cases occur is here. 11 cases, 8 cases, mostly in people that we would consider are almost normal in terms of cholesterol. But if you have, it's a combination of risk and number or prevalence that helps us identify who is at who supports the greatest burden of problem. And so if you want to change the condition of these people, you need to change the condition of everyone in society. And he actually demonstrated in international studies that if you look at the distribution, this is blood pressure across different populations in the world, it looks as if it's the distribution that moves, not the tails that become fatter or slimmer, but it's the whole distribution that moves, so that if you want to improve those that suffer the most, reduce inequities, you have to actually bring change to the whole of society. And so this, I would call, is a structural definition of inequities, and a lot of people actually are convinced and follow this type of definition. I think it's less common because it's also a little bit more complicated, and it's also very generous, and it has a main limitation, is that you cannot increase too much the complexity there. You cannot start thinking in terms of minorities, for example. You won't find in Rose's book words about whether these effects may change, whether you're black or white, whether you're a sexual minority or not, whether you're a man or a woman. Because it's not only a question of interaction. It's not only subgrouping, because once you subgroup, you lose the main foundation of his theory, is that we all depend on all. If we can split our population in parts, then the whole thing disappears. So it has limitation. It's a very interesting concept. But these limitations have been, I think, noticed and have led to a new form of definition of inequities, and that occurred specifically among those groups, subgroups of the population, minorities, women, different races, ethnic minorities, that noticed that the movement of society and the improvement that we could actually observe over all those years didn't work for them. And here we have a new form of definition, which I find, and I call it historical, because I think this definition wants to deal with history on the making. They're not only dealing with inequities as per se, but as inequities in the context that creates them. And one framework is what Lisa Bauleg has developed, and other, which she actually has made it into a very nice narrative, but the origins are much more ancient, and you can actually trace the origin of this type of thinking in the sociology of the early 20th century in Europe. But in the notion of intersectionality, you bring history into your research, into the framework of understanding inequities and trying to modifying them. To the point that there is no more difference or qualitative separation between the researcher and actually the subject, the people that are being studied. This is the definition Lisa Barlett gives of intersectionality, which posits that multiple social categories, race, ethnicity, gender, sexual orientation, socioeconomical status, intersect. And note that, I bolded those words because they are not interact. I'm getting articles from people who actually start to put interaction in their analysis and say, we're doing intersectionality. And I send them to intersectional thinkers and they reject them because it's not interaction. And they talk about intersection at the individual level, but reflect multiple interlocking, against another term, systems of privilege and oppression at the social structural level. Racism, sexism, heterosexism. And public health's commitments to social justice makes it a natural fit with intersectionality's focus on multiple historically oppressed populations. This is, intersectionality blurs the objectivity that most of scientific research claim. There is no more full objectivity since we're part of that history. It's history ongoing, we're part of it, we're making it. And so the way we understand it and the way we act is part of that history. And that's what she says when she says intersectionality has no core element or variables to be operationalized and empirically tested. And so you can find in AJPH other articles that will deal with the same type of definition of inequities that integrate history and history on the making as part of our activity, of our research. So this was what Sally showed yesterday, and she explained that one of the limitations of the activity in public health is that we are working in silos and we should get together and join. I think that's true, but there's a historical context. And what we're doing can be more or less effective in the historical context. And so sometimes, and maybe you'll feel it more today than you would have felt it yesterday, we have to, continue this arrow a little bit more up to be effective. You see the end of the arrow? It doesn't want to stay because it's. But you got the point, okay? And so I'm not saying we should all be activists. I'm not saying that. I just tried to have a look as a historian to definition of inequities across time. I've tried to stress upon you that it's not a fact of the past. It's not just a discussion about the past, but it's something about today, about what we're doing. And history is always with us. I'm a little bit embarrassed because this is a very superficial presentation. Actually, yesterday, one of us said he had been demoted as dean. And it immediately, I said, that's exactly the term. I've been demoted as editor-in-chief. Because, I can do much more. But it's much more superficial. I'm helping people to write their analytic essays and their research paper, but I'm limited to editorials. So just please take this introduction to the discussion as an editorial, and I hope you'll help me to get a little bit deeper into it in the months to come. Thank you very much. Please, we have time for questions. Yes.
Hi, I'm Candace, Community Health Sciences. I have a question about your statement that we can't examine intersectionality with interaction terms. Fair. Is there any thinking around how we can quantify intersectionality in, a multivariable model?
Okay, so that's a great question, because I think it's a question many people are asking themselves. How can we actually translate intersectionality in quantitative terms? What type of methods are needed? Can we do this entirely with a quantitative approach? Do we need mixed methods, etc.? And it's actually an open question. It's a domain in which there is a need for more contributions. But intersectionality is also a theories that are evaluated in practice. So I think a lot of the methods have to be connected with interventions, and these interventions should involve the word of the people that are part of this intervention. So I think the direction is toward an active type of research, and with involvement of the communities into the research, whether it's part of its design, its implementation, or its evaluation. I think that's the way, if I could get those types of paper, I would love it. Thank you. So, yes, please.
I'll just ask what you see in the trends in the journal over the last several years that strike you relevant to the topic.
So the journal traditionally, and the examples I gave, this paper by Barleg, the other paper I showed you, the journal has been contributing a lot to this discussion and this debate. I think the issue of inequities and specifically of intersectionality, of inequities within minorities of all type, has been the strength of the journal. It has innovated there. The first articles on the health of the LGBT community, have appeared there. So it's actually an area in which I think there has been constancy in the journal. What has changed since I took over is maybe more the way these questions are expressed. One of my feelings when I took over was that there were a lot of ideas in public health, and people didn't see where to express them, and sometimes they were taking just data as an alibi, just to express their ideas and their theories and so these were weak papers and weak ideas overall, and so I've tried to separate those. When people take just a survey, sometimes a very old survey, to have some table but have a huge introduction and discussion about, what is their interpretation, what's the importance of it. I've tried to separate those and tell people, well, if you have ideas, just express them as ideas. And you'll find much more of these, and people are actually writing many more editorials or commentaries, or in which they actually, according to how much scholar, research there is in there, in which they are expressing their ideas. And that's the difference that I see in the evolution. Otherwise, AJPH has been the journal who has promoted and nurtured this type of research. I owe a lot to my predecessor for that. Yes, please.
Do you think there might be some ideas about methodologies coming out of anthropology that would help us look at intersectionalities differently?
I do think so. There is we've been publishing a couple of articles of an anthropologist who do self-anthropology, auto-anthropology. Actually, it's an anthropologist who goes to some communities and actually have some specific experience and report their experience. I'm absolutely sure that there is no very strong separation between all those disciplines, that anthropology, sociology, psychology, all those disciplines can actually contribute to the same to the same objective, which to understand those inequalities. And I would say yes. Really, there's a lot anthropologists with their skill that they can bring to this endeavor. Yes?
Mike just shouted. I'm curious about maybe the first question, which is why should we study health inequities? I'm curious about your answer.
Okay.
It seems like maybe there's a feeling inside of us that we should, or maybe there are reasons about maximizing population health that we should, or maybe there are reasons why, in terms of not enough research being done on particular communities, which would motivate you. I'm curious from your perspective why this is important, as opposed to health inequalities, which is all of epidemiology. It's comparing inequalities, population health across different populations.
So why should we study
Health inequities.
instead of?
Well, health inequalities captures all of what epidemiology is, which is comparing the health across different populations. Where it's the same, we don't really care. Where it's different, we care. Why health inequities, which you talked about as differences in health across populations with different levels of privilege and so I'm curious why
Okay.
do you think that's a priority?
Well, I think that what drives us really is a sense of justice. I think that's what drives us in public health. That's the most common drive. I mean, we want to live in a society that is more just. And if we identify health inequities, it is because we want to act on those inequities in order to improve justice. And so that's my simple answer. I think that's what drives us.
I'm sorry.
No, you're welcome.
Thank you. Thank you, Alfredo. I think that was a perfect way to start the day, with an eye at, as Hamilton would say, history has its eyes on us. So thank you. I'd like to introduce the moderator for our first panel discussion today. She's Abby Rudolph. Abby is a professor here at the Boston University School of Public Health, where she's an infectious disease epidemiologist. Abby uses social network and spatial approaches in her methodologies to understand some of these intersectionality issues that Alfredo raised. She's the winner of the American College of Epidemiology Annals of Epidemiology Award in 2013, so very distinguished, and I appreciate you taking on the moderator role, Abby.
So thank you, Sally, for inviting me to moderate this session. I'm happy to be here, and thank you, Dr. Morabia, for your remarks. So the next group of panelists, I'm excited to be able to introduce them. They're going to be giving their perspectives on health inequities from the perspectives of race, class, and disabilities. And I'm going to introduce each speaker individually. They'll come up, then I'll introduce the second speaker and the third speaker. And I'd appreciate it if you could hold the comments to the end. Hopefully we'll have a few minutes at the end, and all panelists will be able to address your comments together. So the first speaker is Dr. Darrell Wheeler. He's the Interim Provost and Senior Vice President for Academic Affairs, and is the Vice Provost for Public Engagement at the University of Albany, SUNY. Previously, he was the Dean of Social Welfare at the University of Albany, SUNY, and Dean of the School of Social Work at Loyola University, Chicago. Dr. Wheeler has also held academic positions at Hunter College, Columbia University, and the University of North Carolina, Greensboro. He's an educator and researcher on HIV prevention and intervention in the African American, gay, bisexual, and transgender communities. And his work has been funded by key health organizations, including the National Institute of Health and the Centers for Disease Control. He's the principal investigator of a CDC-funded study, Black Men Exploring, or BME, which is a randomized clinical trial evaluating the efficacy of locally developed behavioral intervention. And he's also the protocol chair for HPTN 073 and co-chair for HPTN 061, which are both NIH-funded studies. And Dr. Wheeler's used research to advance the use of data and evidence in developing innovative programs and policy initiatives. He also currently serves as vice chair of the U.S. Presidential Advisory Council on HIV/AIDS and is president of the U.S. Board of National Association for Social Workers. He served on the Office of AIDS Research Advisory Council, and in 2015 he was named among the 30 most influential social workers alive today. Dr. Wheeler earned his doctorate at the University of Pittsburgh in 1992, a master's degree in public health at the University of Pittsburgh in 1990, a master's degree in social work from Howard University in 1988, and a bachelor's degree in sociology from Cornell College in 1981. So I'd like to welcome you up to the podium. Thank you, Dr. Wheeler.
You were talking about a stranger. I don't know that person. I was the one who said I got demoted. When you get moved to interim provost, that means they don't want you near students or some such anymore. Thank you very much. I mean, that was absolutely wonderful, and I think we will be simpatico in some issues. The beauty of not using PowerPoint is that I was able to edit some things as we went along, and I hope to address some of the key questions. As part of this phenomenal panel, and Gail, you already did the introduction, and Dean Galea, I really thank you for asking me to be here today. In the time I have, I want to talk to you out of three areas. One is related to my own experiences as a researcher and practitioner in social work and social welfare. I will talk from a historical perspective specifically about issues of race and how race is used in the United States in our health inequity agenda. And finally, I want to talk about some of my own reflections learned from many years of trial and error in some regards about future directions. But before I go there, and again, this is interjected based on comments we just heard, the question was, why study inequities versus inequalities? And from my perspective, it's almost imagining the slide that you may have seen about the difference between inequalities and inequities and resolving them. And to resolve inequalities, everybody gets the same level step stool.
But if you're 5'4" versus 6'4", putting you on the same level step stool, you still can't see over the fence, right? You're at the same, you've got the same lift up. Inequities really addresses the fact that in order for everybody to see over the fence, somebody needs a 2-inch step stool and somebody needs a 4-foot step stool to be able to look over the fence. And so the role of inequity resolution addresses that complex fact that everybody doesn't start at the same place. I will deconstruct that a little bit more. The question and why I think we need to do this is, do we really want people just to peer over the fence, or do we want to move people over the fence, or more justly, do we want to eliminate the fence? And so the question at the core of the inequities versus the inequalities is the inequalities studies how those things got there, but the inequities should address whether or not people should be going beyond the fence, or what is the rationale for the fence being there in the first place. So that's my naive perspective on your complex and well articulated question. So now on with my presentation. Regarding my own research, I've come to a deep appreciation about the difference between race, racial identities, and racialized identity. So race, as a social construct, are these categories that we use, and we use them in almost all of our studies, and the federal government mandates a certain set of boxes that you will check off or not, and if you don't, you're in violation of some OMB guidelines, and you could be in a lot of trouble. But that's about as far as it really goes. Because when you really think about it, for each and every one of us in this room, if we were to check the box, I still don't know what that means to you. And that goes into your racial identity. How you begin to internalize what that box means to you is a critical component. And one of the valuable lessons I've learned in my own research is to listen to what that box means to people. And that is still different from a racialized identity, which is typically your social manifestation of your racial identity. So you may understand yourself to be of a certain racial identity as an African-American gay man standing in front of you, and I internalize some of that, but how I play that out as part of my social racialized identity, which rallies I attend, which programs I accept, which groups I do, starts to speak differently about how I manifest that, which is not the same as how I internalize that. And it actually begins to go into that research that Lisa does in intersectionality, and I just want to say one thing about intersectionality. Those of you who have studied systems understand the concept of a holon, which is greater than the sum of its parts, right? And so that thing that is intersectionally derived does, and why it's so complex and why we have to really critique or interrogate when people want to simplify that back to the boxes, is that the intersectionality, as the men I'll talk about in our study have taught me, is that they come with all of their identities in this new amalgama that doesn't look like any one of the identities. And so I can't separate out the sexual identity from the racial identity, from the economic identity, from the neighborhood or the geographic, because they're all embodied in one being that is not like any of the individual constituent parts. And so when we go to measure that using some of our naive perspectives and methodologies, we really underrepresent the impact of those intersecting identities that now manifest in a new and powerful way. And then when those come in juxtaposition with an external world where you, the outsider, perceive me based on either what I've said or what you heard about me or what you see, it now becomes about your interpretation of who you think I am. And when those two worlds come into contact, then all bets are off, because now we're talking a new territory. It is about, and let's go to the cliche, how many of us ever heard start where the client is? I say nobody starts where the client or patient is. You start where the client or patient is, where you're capable of being, because you're part of the equation. On with my presentation. RO1 does not equal ROI. Second lesson learned. Getting a funded research project is a feather under my cap, but but absolutely means nothing to the individual who's homeless, living in a marginalized situation, and comes to the door for the study because he's looking for remuneration and I'm looking for data. My R01 is only a vehicle for him to get something. So R01 is not the same as ROI. I just said starting where the client or patient is much easier said than done. And finally, context matters. That the context, as we've heard, in which you experience any given moment is crucially important, because the way I see the world today on the 1st of February 2017 may have looked a little bit different, and pardon the political reference, the way I saw the world on November 7th, 2016. And context matters. So when we talk about, I won't get into that. I've been fortunate, we could talk about that in a Q&R. I want to make sure I stick to the script so I give time for my other panel members. HPTN 073 is the one study that I'd like to talk to in the short time that I have. HIV Prevention Trials Network is one of the many NIH-funded networks that explores ways in which we can impact the HIV epidemic. And the name says a lot, prevention. The focus is on prevention. And given the fact that the Centers for Disease Control in 2016, here in Boston, unveiled a study result that indicated that African American men in the United States, black men who have sex with men, have a life course risk of HIV 1 in 2, 50% in the United States, a life course risk of acquiring HIV in the United States. That is worse than, 1 in 2, that's a flip of the coin. That should not happen in a society that espouses itself to be equitable. And we have to realize that that is the context in which we do this work. We've known for some time that pre-exposure prophylaxis has a benefit in preventing the acquisition of HIV, but even though we've had studies, we've had few studies, and I was fortunate to be part of HPTN 073, and our N was ultimately only 226. It was the first large-scale study of African American men, domestic African American men here in the United States, where we were really studying that group to understand 3 core questions. Would men accept it? If they accepted it, would they take it? And if they take it, will they adhere to it? And ultimately, will they benefit from it? The study was conducted in 3 sites, and we used a culturally tailored intervention, and I think this is key. The intervention was called client-centered care coordination, and when I say culturally tailored, and where context matters, in the 30-year history of HIV in the United States, this was the first study funded in the network that had funded many, many studies that had ever been led by a black man in the United States. And that happened to fall on my shoulders, and that was only 3.5 years ago. The first time that that had occurred, all eyes of the world were on us. 3 sites, Los Angeles, Washington, D.C., and Durham, North Carolina. We enrolled 226 men. We excluded by way of recruitment easily a third or 200 more men, and most of those men, at least a third of the men that were excluded because of pre-existing conditions, biomedical conditions, mental health, and or housing instability, because one of the requirements was that you couldn't be immobile in moving jurisdictions because we wanted to be able to follow you. We had a 79% self-reported uptake of PrEP, so 79% isn't bad, because the first question is, would men accept it? And they said yes, they would accept it. We had a 50 to 67% concurrence between self-reported and biological measures of optimal levels of HIV. Of Truvada use, not of HIV, I'm sorry, of Truvada use, which is very good because the biological marker highly correlated with the self-report, and we needed to affirm that men were actually taking the medication. So would they take it, and would they actually adhere to it? So we're seeing 50 to 67%, depending on which of the drug components and combinations you looked at. And ultimately, regardless of whether the men took the Truvada or not, we had 90% retention a year out. Now, how many of you would like to have 90% retention in your studies? And I tell you, given the fact that we were the first study headed by a black man, and then I compounded the trauma by making sure that my co-PI was an African-American gay man, my behavioral scientist was an African-American gay man, and the interventionist specialist who developed it was an African gay man. Boy, oh boy, the first time ever. So we're going to get into what, thank you. But when we presented the results here at Croy last year, that was the question. How did you retain men? And since then, we've been really focusing on this role of the C4 intervention as a culturally tailored intervention that dealt with this concept of intersectionality, because we truly tried to listen and start where men were. So if people came to the door and said, I am not necessarily here for prep, but I'm homeless, we started with the homelessness. If men said, I've been incarcerated and I need someone to help me, we started there. And during the course of the time with the intervention, we moved into the acceptance of prep and then stabilizing men to make a critical decision. So I think that was important. What were some of the barriers in the study? I already said that more than a third of the men that we recruited were ineligible because of pre-existing conditions. The role of structural factors, unemployment, poor income, even though men were highly educated. We had more than half of the men had high school or college, but their incomes and employment were actually at 20, 30%, which is significantly greater than the general population. Issues of incarceration, substance use, and experiences of stressors associated with sexual identities and provider system barriers. Some of the facilitators were the linkage to the staff, and we actually found out that some of the men were just really happy to help this group of 4 black men trying to mount this study, that had an impact on the men themselves, that they wanted to stay connected to a study that looked like them and was created in their image that was intended to produce a positive outcome. And we had a willingness of, and I said the C4, and a willingness to capitalize on this to produce change. Now, I want to talk historical, and I make a rapid transition from our C4 intervention in HPTN 073, and I want to go way back in time. And so, thank you, Dr. Morabia. You really set the stage for me. But a discussion of equity has to be set against how we got there in terms of racial disparities. And so when we think about Linnaean classifications of the biological basis of differentiation, and we go back to 18th century studies, from kingdom, phylum, class, order, family, genus, and species, we note the absence of the word race. However, when we move forward slightly into the European age of enlightenment, we get an interjection of the term race to substitute for the term species. And it's interesting to note that that interjection comes at a time of colonization in the United States, and the term race being predicated on the development by German scientists of the basic classifications of what I lovingly and humorously call the basic food groups. And you know what the basic food groups are: Caucasian, Mongoloid, Malayan, Ethiopian, and American. So it's the red race, the black race, the white race, the yellow race, the brown race were the categorizations. Those categorizations in the Enlightenment period, substituting the term race, are all coming together in a time, and notably, when you really examine and critique the literature on that, the observations from the Enlightenment period weren't even done from an anthropological perspective in terms of firsthand research. They were done by observation of what was going on in North America and the colonies of the time. And that has a profound effect on the introjection of the term race, because what was being done in the United States was a very intentional utilization and a denigration of the human entity in service to forced labor, also called slavery. And therefore, the characterization and dehumanization of individuals based on those morphological characteristics, right, was done in a way and articulated in a way that the substitution of race for species became the lessening of the human quality, so that subjugation of the individual because they were not human. That you got the monstrous or the Ferris kind of individual versus the good human, which was characterized and normed against being the Caucasian or the white. Without that kind of historical understanding, we kind of look at those boxes that I talked about as naive things. They're not naive things. They are socially constructed not just for the scientific capacity to be able to differentiate, but let's own the fact that in the United States, they're constructed for political, economic, and social value. That the declassification of the human being and relegating the human being, the African American, the red person, the brown person, to less than, enabled, as we saw in data that you presented, that would have, if we looked in the United States, 1/3 of the human, 2/3 of me would have been counted for purposes of cattle call in those days of early enumeration, because you needed the population, but you couldn't make me 3/3 of me, because that would mean that I'm equal to you. And so that's a lot of, we really have to have that entrenched in our thinking, because otherwise when we go to trying to measure things, and especially around race, there can be a very naive approach to the benignness of the categorization and the utilization of the term race. And race and equality in an environment where there has never, ever been equality. And I underscore that. The United States has never known a point where equality and equity has been the norm. We're striving in this era, and as scientists and as social scientists, behaviorists, biomedical researchers, I hope we're reaching for the issue of social justice. We're going on uncharted territory. This uncharted territory is something that we think ideally we have an eye or a handle on, but it's never been done before, and certainly not in the United States. So that was the history lesson. I talked a little bit about my research, and I know I only have a couple minutes left, so I'm going to go to what I think are some ideas for meaningful change. I got 3 of them, and then I'll shut the heck up. Use terminology meaningfully and impactfully. Translate your results into formats that can reach the general population. Continue to examine the work of the provider as a force in the equation with the patient. Increase the movement to social and economic issues as well as just biological. Make sure that we combine the issue of outcomes, not just for minority populations, but shifting the whole. Because in this era, if the value is not seen for all, we're really in trouble. And starting where the client is requires that we are critical of ourselves in order to be present. Thank you. Sorry about that.
Thank you, Dr. Wheeler. I'd like to introduce our next panelist, Dr. Laura Lein. She is the Katherine Reebel Collegiate Professor of Social Work and Professor of Anthropology at the University of Michigan. Dr. Lein served as Dean of the University of Michigan School of Social Work from 2009 to 2016, and before that she was at the University of Texas at Austin School of Social Work, where she taught for 24 years. Her teaching has spanned across social policy, social work, research, and community organization and participatory research. And over the last 3 decades, her research has concentrated on the interface between families in poverty and the institutions that serve them. She's also the author and co-author of, I think, almost 9 or more than 9 books. So I'd like to introduce Dr. Lein to the podium now. Thank you.
Great. Thank you. Okay. Thank you very much to for having me here today. And I wanted to just make a couple of points introducing myself. I'm an anthropologist by training, and I've spent most of my career living in communities that I study and trying to work with the people I meet to understand the ways in which they make decisions and what ramifications those decisions have for them. I also wanted to say that unlike many anthropologists, I did almost all of my work with wonderful teams of people. That's one of the teams up on the slide there that came out with me and often settled in communities for a certain amount of time while we did our work together. I had some hope as I grappled with this complicated topic, knowing that I would follow Darrell, who did such a thank you, Darrell. Thank you. Who did such a masterful job of explaining the complexities of trying to categorize who people are and what the ramifications of that are. And so when I was asked to talk about class, I knew I was going to be talking across a whole group of kinds of people and communities, and that I myself was also marked as an outsider in those communities while I studied them. And I thought Darrell inspired me to start with a story that I hadn't included before about why would anybody in a struggling community of color or poverty community talk to me? What did I look like, and why would anybody interested in confiding in me? And I learned that the answer to that question was how explicitly self-revelatory I was. People had to know me and know about me first. And I was blessed, I guess, in my first field work in Texas, which is where I did much of this work. When I was working there, the first summer I worked there, we had just adopted a little boy who was 3 years old and was having a terribly difficult time and spent much of his time clinging to me and screaming or running away from me and screaming. And I was pretty worried because he was with me while I was doing my field research in a primarily Mexican-American community. And I wasn't sure how I was ever going to meet people and talk to them in detail while I was accompanied by this struggling child. But the interviews went astonishingly well from early on. And at one interview, I was talking with the mother of another little boy, and she said, "You know, Laura, you're very easy to talk to." And I said, "Well, I'm really delighted. I enjoy our conversations too, but could you tell me why you find that so?" And she said, "Well, I can tell you why it's easy to talk to you. We know about people like you. You come from a university, you're white, your Spanish is lousy. People like you come into our community and they start looking at how we parent, how we raise our children, and pretty soon it transfers into what we should do differently, what we can do better, what we don't know, and how we need to know more. But you know, we get to watch you with him, my son, and you have nothing to tell us." And that turned out to be a great starting point for doing field work. So what I wanted to do here was to very briefly look at the problem in more general terms, but that's not really my specialty. So I then want to go to work to examine questions through the lives of people in the pictures here and otherwhere in the slideshow to give examples of what happens when people trying to acquire some kind of health service, deal with some kind of problem, face what Darrell referred to as the fence. What is it? What are they dealing with, and how do they deal with it? Because the question I want to look at here is, why is it that people can be working hard with devotion to their family and children and appear to outsiders to be making very poor decisions about their health care, when my analysis indicates that they're often doing the very best they can under extraordinarily difficult and usually understood circumstances? So I want to go and look at what this looks like and then talk very briefly about what some solutions might be to understanding this. So just to do a couple of general things quickly so I can say I did them. I know this is stuff you all know. Health varies by income. as we all know. And this is just a report looking at people's self-reported health by income. And it has all kinds of reasons, which I'm going to delve into a little bit. There can be environmental issues. There's issues about access to insurance. And then once you have insurance, can you actually get access to health care? There's the lack of the wherewithal for good hygiene, basic preventive health, good nutrition. And people can have limited resources for following up on whatever the suggestions are of specialists that they see. But all of this comes back to the fact that health is related to income. This, again, is a brief chart just illustrating the relationship of insurance to whether or not you have access to care. Insurance clearly helps, but as we're going to see in some of my examples, it's not the answer. And I wanted to, I'm skipping that slide for a minute because when I looked over things, I wanted to reverse the order. Sorry about that. We also know that more recent analysis is indicating that poverty is not a particularly good primary variable, that inequality, inequities, actually have dire effects on health over and above the impact of poverty. And this is an international comparison looking at inequality, economic inequality against rates of infant mortality, again, which is fairly commonly known to this group. So I want to go back and look at families and why it is that their health care seems so complicated and so hard to get, even when they might be pretty much eligible, as we would see it, for public services, public insurance, and public care. So this is a family in San Antonio that turned out over a several-year period never had everyone qualified for health insurance, even though they were extremely poor, in the lower than 50% of poverty line. So what's going on here? What in their case was preventing them from maintaining health insurance? And this is from Medicaid pre the Affordable Care Act. So we're looking at it from that standpoint. But what we discovered with this family was that one of the big trials that they faced in maintaining their eligibility for care was the ways in which housing evictions are handled in Texas. And it turns out that that's entirely a local matter, how evictions are handled, and that it varies wildly across communities. I was working in San Antonio in partnership with people in other areas. In Texas, you can go from first notification of an eviction to eviction in 15 days. And so this means the first you hear that you're in trouble can be 15 days from when a sheriff arrives to put you out on the street. If your insurance coverage, as Medicaid did at the time, depended on being responsive to mailings that came in ordering you to come for reapproval, that you needed to appear for certain kinds of checks, that you needed to go through certain kinds of hoops to maintain your eligibility, you were very unlikely to receive them if you were in the middle of a cycle of evictions. And this family found that one or another child was always rolling off of health insurance without their knowledge. One of the most marked things here was the degree to which people didn't know whether or not they were covered because the system itself was so complicated to deal with. Another issue is the way in which, in addition to fragmenting the services we offer people, we've fragmented medical care itself. One of my colleagues refers to the ENTLs, the degree to which coverage may or may not include mental health care, dental health care, optical care. The map there is showing in 2016 the considerable difference among states in whether Medicaid covers dental care. That's a family we interviewed in far West Texas that Our viewer, the student who was doing the interview with that family, came back very disturbed. She'd gone out to the small farm and was talking to people, and a young girl from the family came up. And when she smiled, it turned out she had braces on her teeth that were completely corroded. And she asked the family about it in the course of the conversation, and they explained that they had always been told their daughter needed orthodontal care or she would start losing her teeth. And finally, they had gotten access to a clinic that was about 60 or 70 miles away, and they had been able to get braces put on her teeth and to launch dental care in a program that was separate from their other coverage. However, that clinic lost its funding to provide orthodontal care, and they had no other clinic available to them. They were too frightened to remove the braces themselves, but they recognized that they were in dire straits now. And they're still working through what to do. Another example of how this expands and really affects all of us. We were talking with another family where the mother in the family was explaining that she felt like she was losing her vision, but she didn't have access to optical care. And she was, because the job that she had didn't cover optical care. So as we talked, she was talking about the impact of losing her vision, and I finally asked her what her job was, and she was a school van driver for the public school system in the area who was losing her vision. Again, because the services themselves are fragmented, we tracked for another family what the process was for them, and this is in a rural area, to get a healthy baby checkup. The family was indeed eligible for Medicaid, and they got through that process. But the Medicaid system had a special program, Texas Health Steps, excuse me, with which you had to engage to get a well baby check. And then you had to find a clinic that took both Medicaid and Texas Health Steps funding. And if you were out of town and you needed transportation, you could go to the Texas Medical Transportation System, which would agree to send a van within a 2-hour window to pick you up, take you to your appointment, and then bring you back within a 2-hour window. But when you added that time all together, you were gone from home for a day, and the mother lost a day of work, usually the mother. And as they carefully explained, you could not bring any other child on the bus except for the one with the appointment, so you also had to identify child care for any other young children you had. And so families that made an appointment and couldn't keep the appointment became labeled as poor performers in the system and had more trouble getting the services of it. And you can see how easy it would be to fall off your appointment at any step in this. Two, 3 minutes? Am I up? 2 minutes, okay. Another area to watch is what happens to people who are in harm's way in a national disaster. This is looking at New Orleans in terms of how much water people got. And there's fascinating geographic research looking at the actual inches of water that you were at risk of getting compared to your household income. And it was clear that family neighborhoods were being built at lower levels, greater number of feet below sea level, the poorer the neighborhood. And so you practically see a direct relationship between feet of water and the income of the neighborhood in general. This is my last main substantive point. This is very hard to read, I know, but I'm going to give you. This is a graphic of threads of funding coming into Austin to support Katrina evacuees. The left-hand column is sources of funding. The right-hand column is agencies, and there are several ranges of intermediate places this funding goes through. But the short story here is that each of those lines is a separate funding stream with a different start date, stop date, and criteria for funding. That our families, in order to get help, had to get case management and then articulate and go through in order to get the services they needed. And it's not surprising that many of them fell by the wayside. So with these kinds of issues, what can we do? I think the first thing we can do, do I have time for one more story? Okay. I want to tell the story of why I fed my children Kool-Aid and soda when I lived in a poor neighborhood, because I think we first have to understand why people are doing what they're doing. So I lived in San Antonio for a brief period, and during that summer, the largest meatpacking company in the southeast United States lost its air filtering system, as it did every summer. And the unfiltered air came out over the neighborhood, making the neighborhood smell like tainted meat. And most children stopped eating because their food tasted tainted to them as they tried to feed it. And most parents told each other, and were told by others, forget food, think fluids. You're in a San Antonio summer, it's over 100 degrees. If your children don't drink, they'll die. And so most of us tried to water, too bland. Milk, too bland. Our children wouldn't drink it because it too tasted tainted. When you wanted to get fluids down children, you added sugar. And that worked. And I found after a week of struggle with my kids, I too was a Kool-Aid fan. So I think in times of, when we look at families and these kinds of stresses, we need to look at prevention. We need to look at services that are universal and easy to access. And we need to think about the fact that families in poverty are probably making decisions that are, in fact, good choices given the choices they see arrayed before them. Thank you. Sorry I went over.
Thank you, Dr. Lein. I'd like to introduce our last speaker. We're a little bit shorter on time right now. Dr. Jay Berry is going to speak on disabilities. He's an assistant professor of pediatrics at Boston Children's Hospital and Harvard Medical School. As a general pediatrician and hospitalist, he coordinates care for children with complex medical problems and needs. His quality improvement initiatives and health service research have focused on optimizing health outcomes and reducing unnecessary resource utilization for children with medical complexity through proactive care planning, integrated health information management, high-quality discharge planning, and use of home and post-acute services. He also leads the International Complex Care Quality Improvement Research Collaborative sponsored by the Children's Hospital Association. Jay?
Dr. Backman, Dean Galea, thank you so much for having me here today. Dr. Rudolph, thank you so much for the introduction. For our fellow panelists and for all of you here, I'm very excited to talk with you for a few minutes about this topic of health inequality in patients with disability. Now, there are so many storylines in that to convey. I wish that we had like 2 weeks together to get through all of this, all right? But over 10 minutes, I wanted to talk about the topic within that bothers me the most, and I think that we need more action on helping. And that is the intersection of clinicians who are enabling health inequalities for patients with severe disabilities. All right? That's what I want you to think about now and hopefully further after this talk ends. So a few disclosures before we get started. I'm a general pediatrician. That is my vantage point around disability and health inequality. I had a bunch of great, phenomenal, fantastic clinical research and policy mentors in neurodevelopmental disabilities that really pushed me to take care of those patients, and most of my patient panel involves children with severe disabilities, including those with cerebral palsy, spina bifida, congenital brain malformations of that nature, managing them from the general pediatrics standpoint. I also have to disclose that my wife, who I think is the most wonderful wife in the world. In fact, if there were U.S. News and World Report rankings, she would probably be ranked #1. And if someone in the back of the room wants to tweet that, that could probably add 5 to 10 years to my marriage, which would be absolutely wonderful. My wife is a geriatrician who spends all of her time caring for patients with advanced dementia. And she's very vocal and opinionated, and she's definitely influenced the way that I think about things. You know, it's largely from discussions with her when the kids are put to bed and the dishes are clean and the house is clean, which usually happens like once every 5 years, that we get together and talk about the health system for our patients and what's enabling or disabling them. Recently, we've been asking ourselves some difficult questions, which I wanted to convey to you and ask these to you as well. Recently, we asked ourselves, so what kind of patients do clinicians typically prefer to take care of? What kind of health problems do patients have that clinicians would prefer, have a greater affinity for taking care of? And we came up with this list. It's certainly not exhaustive, but things to think about. Patients with health problems that are fixable, that are interesting to treat, that are relatively easy to treat, that we can treat on our own without a lot of help from other providers, where patients are satisfied when we treat them, and then maybe the health problems that we're treating tend to reimburse us well, all right, candidly. Well, then we said, all right, on the flip side, so what kind of patients do clinicians on the populace, generalizing and hugely stereotyping here, would not want to prefer to take care of, that would not prefer to take care of these patients? We said, well, it's the flip side of all those attributes. Maybe it's patients with health problems that are incurable, that are much more difficult to treat, that may not be as physiologically interesting to us, that may not reimburse well from insurers, that take a lot of people and a lot of time to take care of, and where patients and families a lot of times may actually be sort of unsatisfied with their health and their health care. So then we kind of carried this thought experiment further, and we said, well, across the swath of patients out there and all their health problems, are there some health problems that patients experience that may be, more times than not, placed by clinicians in that category of being not preferable? And that's when we started to think about individuals with severe disabilities. I started to think about children in my own patient panel, so many of our children with cerebral palsy, spastic quadriplegia, very severe disabilities, functional status impaired in the digestive system, respiratory, skin, musculoskeletal, endocrine problems, et cetera. It takes so much time to try to manage the care for those children. It's really, really, really difficult. My wife then came back and said, well, you know, what's interesting, all my patients with advanced dementia usually experience a lot of those similar health problems. And even though the neurologic base of that problem is very different, the patients end up having the same types of obstacles that they're experiencing in their lives. Then we started to think about, all right, so let's think back through our training, through medical school, through residency, through fellowship, and even now. You know, are most clinicians that encounter patients with severe disabilities, regardless of the setting, sort of jumping up for joy, up and down, I'm so glad I have one of these patients in front of me to take care of? When one of these patients shows up at the emergency department, or they're hospitalized, or they're in the intensive care unit, or they show up in a community pediatrician's primary care panel. We started even thinking about neurology, which is are there any neurologists in the room before I bash you? Fantastic. So these are predominantly neurologic-based conditions a lot that lead to disability. But I think that we find, at least in pediatrics, and I think some in geriatrics as well, that maybe the neurologists aren't standing up to say dementia is our disease, even though it's neurologically based. Same with some of the neurologists as well for cerebral palsy and other things. They're fantastic at handling epilepsy and certain problems, but they're not really stemming up to take charge to manage all the children's and health problems and also on the adult side. Now, certainly, there are providers out there that really go into their careers purposely trying to help individuals with severe disabilities. I think the gerontologists are one example, folks who are trained in neurodevelopmental disabilities, physical medicine and rehabilitation docs, et cetera. But I think that the supply of those clinicians is really insufficient to meet the demand of individuals out there with severe disabilities who could really benefit from having them. And I think that that really does impact the health and well-being of individuals with severe disabilities. And in the children's world, when you look at a child with severe neurological impairment, comparing those children to other children with other chronic conditions affecting other organ systems, the kids that really do have the severe neurologic problems, we think, are the least likely to have a primary care medical home, are the most likely to have existing unmet health care needs, are the most likely to use the emergency department, to be hospitalized because they get sick so often. And their families are one of the most likely to have a lot of trouble trying to navigate through the healthcare system and do a lot of the job that I think the clinicians should be doing to coordinate the care for the kids, which results in marital discord, loss of employment, financial difficulties. I mean, I really do think there's an effect there. You know, thinking through this, the saddest thing about this, I think this is what really bothers me, and I want you guys to think about, is that, you know, just as patients don't choose their race ethnicity, it's sort of fixed in all of us, right? Most of them also don't choose which chronic conditions they end up experiencing, especially those with severe disability. There's no choice there. But on the clinician side, we do have a choice of which patients we prefer or not to take care of. And I think that preference drives the quality of care that we deliver for these individuals. So when Sally talked with me about giving this talk, she's like, look, if you get up there, don't just state the problem and walk away. You've really got to deliver on how we can make things different. I really don't have the answers on how to do that. And I should have disclosed that to you before I agreed to give the talk. However, I think just raising awareness of this and starting to talk about it, this is the first time I've ever talked about this publicly, I hope would end up making a difference. You know, I also would hope that of all the individuals, clinician-wise throughout the country, who really are embracing the care for individuals with severe disabilities, that they would step up as well and figure out how to charge young clinicians and everyone else coming into the workforce to say it really can be unbelievably rewarding. You can deliver super high quality care to these people and make a difference and reduce and eliminate some of the health inequities that we think are out there. On the insurance side, I mean, I would absolutely love it if they tripled reimbursement for the amount of time that it takes to care for these individuals, and maybe that would make a difference as well. All these things combined, I hope, would sort of move the field forward so that we can do what we can to help these individuals with severe disabilities, because frankly, I just think they deserve it. Thank you.
Jay, stay up here, Jay. So what we're going to do, I just want everyone to know that I do have my eye on the clock, so not to worry. Abby's going to be convening a panel, which we're going to do for probably 10 minutes. Then we'll take an 8-minute break, and we will then move into the next session. I want everyone to know that we have built in time in the agenda. So for those of you who are kind of watching the clock and wondering if we're losing time management here, I want you to know we're on it. So if all the speakers, including Alfredo, Laura, could come up, Abby's going to take a few questions.
Yes? Did you raise your hand?
So the first thing in the morning, Alfredo, you came up and had a wonderful talk, but you said that we can't separate by different factors. We have to look at the whole picture. And then the next three speakers came and separated people. So I guess the picture is more complicated than both, but could you talk about, or all of you guys talk about that, and how it kind of plays a role together, or the truths about both sides of that?
Well, let me maybe just start. I said that the most common way of defining inequities was to actually identify a subgroup of the population and try to do something for them. And I said it worked. And this is what we see. And so it's not really a contradiction. I think there are other theories that try to address those problems in a more complex way, and I try to describe them. But I didn't say that they were more effective. I think that they may better explain what we see. But maybe when it comes to action and practice, there is they converge, actually. So.
Yeah. it feels as if that last statement is the true take-home message. I mean, even when we were talking last night at dinner, Laura asked me, well, how much of social class are you going to talk about, and how much of race are you going to talk about? I mean, infirmities. I mean, the individual, the intersectionality exists, and I think the reason for the discussion of disaggregating it was because in our way of studying, we study of the constituent components, but I don't think any one of us is articulating that someone with an ability or disability doesn't have a race or a social class, but for the purposes of discussion, we're looking at the constituent parts. It's like an organism that you would study. It has elements that make up the organism, but the organism is the thing that you're looking at.
You know, I would just add that when I feel like I'm on my A game clinically with the patient in front of me, if I'm doing the best job at getting into the weeds of them with whatever I'm trying to do, their disability is invisible, their race is invisible, their social class is invisible. You know, I'm really at the core of trying to help them regardless of all those things to make their health and well-being the best it can be.
Rich?
Hi, Rich Sates, Community Health Sciences. My question may be for any of you, but maybe particularly for Professor Wheeler. And I want to preface my question by saying that I'm a middle or older age white man, and I asked this question taking some risk, and I just want you to know that I'm coming from a place of trying to understand. The discussion this morning, two of you mentioned the curve and moving curves over and addressing the whole population. And yet, in the public discussion, I hear about Black Lives Matter and a real strong push to not call that All Lives Matter. And I understand why. I think I understand why. How can I think about both of those things together? That is, focusing on a population that we want to focus on because it's gotten less focus and maybe needs attention, and at the same time trying to move the curve over.
The way I would think about, and I appreciate you risk it, in response to your question and being put on the spot, I think it's important in the historical context to begin where you ended that comment and to say that Black lives in the context of the United States have been denigrated, and what people are actually calling for is an articulation. So for example, I just had a communication with folks with regards to, and this I'm going to risk, when we talk about the executive order recently signed and the impact on undocumented and different immigrant groups, the narrative that we were going to put out as a university was applauding the narrative discourse about this country. But you can't applaud the narrative on immigrant status when many people didn't come here as immigrants. They were forced to be here. And so it's going back and constructing a narrative that says, yes, we have an ugly history in this country, and you're absolutely right. We didn't appreciate that Black Lives Matter. How can I fold that into a broader agenda as opposed to people hearing or people saying, oh, we're beyond that? And I think that's where we got in trouble. I don't think people are totally opposed to it, but what folks are really anxious about is, will you acknowledge the ugly side of who we have been as a country to get to where we are today?
Oh, yes, go ahead.
Yeah, your point is very important, I think. And I want to tell you my experience, because you may know that last October we had the issue of AJPH was about the public health legacy of the Black Panthers. And in January we had the issue was on the public health legacy of the Obama administration. So I discussed with lots of people, and I tried to get into those topics and understand them a little bit. And one thing that strikes me is that even though the Black community, starts with its own problems, in the ghettos of California or wherever, the solution that the mainstream of that community have been proposing always were always universal. I mean, strikes me about the Black Panther. The solution was not for the black community, but for everyone that it was oppressed. And I just wrote this editorial. I'm back only to editorials now, but about the Obama family. I think the greatest contribution of the Obama time as president has been the role model of the Obamas in the White House. And the role model, because not only were they, a beautiful family, very respectful of all universal values that we can have, and if people, were following this example, it would have a huge impact on public health. But also because they were, clearly connected to their origin. They went to Africa. They were an African American family in the White House, but the values that they defended, of respecting everybody in terms of religion, in terms of sexual preference, in terms of gender, etc., were universal values to which we all aspire. And I think today, more than ever, when I wrote this editorial, people say, well, you're going to, kind of write an hagiography of the Obamas, etc. And it was at the time where people were thinking we would have another government. And now with this government that we have, I think even more than that, we see how universal, So when Black Lives Matter say, we have to look into what, is the real existence and experience of Black lives, I don't think that in the answers, in the solution, they view themselves as sectarian, as isolated from the rest. That's my experience.
I am very sorry to be the person in this role today, but I want you to know that we're going to be having more conversations, and we have time in the agenda. I want to say thank you to our distinguished panel. Thank you to Abby for doing a great job organizing it. We're going to take a 5-minute break, and then we'll come back and reconvene.